Hello, everyone, and welcome to today's Ending the HIV Epidemic Learning Collaborative session on at-home HIV testing. My name is Elena Rosenberg-Carlson, and I'm the Ending the HIV Epidemic Coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIPS. Please take a minute to introduce yourself to everyone by sharing your name, your affiliation, and your location in the chat. We've received a lot of interest in today's topics from partners across the region, so I'm just really pleased that we have 3 wonderful presentations coming up this morning on different at-home testing programs being implemented here in California. And the last half hour or so of today's session is reserved for panel discussion on some of the great questions that you all submitted during registration, and then we'll also have some time for open Q&A on questions submitted during today's session. So before we get into our first presentation, I just have a couple of reminders. As usual, please feel free to submit any questions you have at any time during the session using the Q&A button on your Zoom control panel. And again, the last portion of the session will be dedicated to answering your questions, but we'll also try to answer some questions throughout the session. We will be keeping the chat open during this session as well. So you can all share any relevant resources or information with each other during the discussion. But again, please use the Q&A function if you want to submit any questions. And also, we are recording today's session and we'll be posting it on the EHE Regional Response webpage within the next couple of days. So now I'm delighted to welcome our first presenter, Obia Leva, who is the Community Education and Testing Manager at Contra Costa Public Health, and will be sharing their Home is Where the Swab Is program with us today. Welcome, Obia.
Good morning, buenos dias. So my name is Obia Leva, and I am the Manager for Prevention Services with Contra Costa Public Health, the HIV AIDS and STD program. And also joining me today for the Q&A period is Via Wild, who is our surveillance coordinator here in our department. Thank you for inviting us to talk to you this morning about our at-home HIV testing program that we began in late April, providing services in the county through a program we're calling Home is Where the Swab Is. So basically what that is a confidential, free, contactless HIV and STI testing in the comfort and privacy of a client's own home or private space. Just to note, the reason why we capitalize home and swab, it's really, it's more of a marketing strategy to kind of let folks know, where the services take place and how the services take place. Next slide. So a little bit about our sort of life before COVID-19 pandemic here in Contra Costa County. So we're a medium-sized county, Contra Costa. We're located in the San Francisco Bay Area, just north of Alameda County and across the way from Marin and San Francisco counties. We're also part of the TGA with Alameda County. And in our life before COVID, we're a little bit different from other counties in that all of our HIV testing services are provided by in-house staff, so we don't contract out services. All of our counseling and testing counselors are county employees. The same goes for our medical case management. Most of our medical case managers are also county staff. And we have, I think, we have one a contract with Lifeline Medical Services in Richmond, so they have a medical case manager there as well. And so they provide services to over 600 HIV positive folks in the county. So before COVID, we had a very robust community focused community testing program where we had mobile testing services, and on the slide you can see that's a picture of our mobile testing unit. And we also partnered with about 20 agencies in the county to provide either weekly or monthly testing services at their sites. And so we provided rapid HIV testing and also rapid hepatitis C testing. And then last year, for about 6 months, we provided at the Rainbow Community Center, one of our prevention contractors, we provided the 3-site STD, gonorrhea, chlamydia testing services as well. We also have we have a PrEP education and navigation program. Those services have continued to be provided through the pandemic. We are a PrEP app enrollment site as well. And then about a year and a half ago, we started a health navigation program for new positives. In that program, we partnered with the six Planned Parenthood clinics in the county. So whenever they were about to give one of their patients an HIV diagnosis, a new diagnosis, I would assign one of our disease intervention technicians, one of our testing counselors, to go and be there to meet with the client after they were told by their provider of their diagnosis, and to offer them immediate linkage to care to our medical case management services and our HIV care services in the county. Our county also has our system of care for HIV. We have 4 positive health clinics in the county. There's county clinics, and they provide medical services to people living with HIV. We also have 3 sexual health clinics in the county, and before COVID, they were evening clinics, so we would be able to send folks, for testing and treatment for STDs to the sexual health clinics as well. And then about, I would say like 2.5 years ago, we started our data to care intervention. And that's basically our line list intervention. And that's where we created a line list for our DITs to call individuals that have been diagnosed with gonorrhea, chlamydia, or folks that are co-infected with HIV and gonorrhea and chlamydia. And what they do is they follow scripts, and they actually call folks to first make sure that they've gotten treatment for their STDs, if not, link them to treatment, and then offer them education and prevention services so that they don't get reinfected. And the line list has continued throughout the pandemic because that's done on the phone. So that's via phone services. And then in our program, we also have 2 prevention contractors. We have HEPAC, the HIV Education Project of Alameda County, Prevention Project, Alameda County, and they are our needle exchange service providers. So they have 2 sites where they provide weekly needle exchange services in our county, and those services are essential services, so they've continued throughout the pandemic as well. And then we have the Rainbow Community Center. And their contract with us is they educate their clients, particularly men who have sex with men, about PrEP, and then they connect them to our PrEP navigation services, and then also our testing services. And they've been really, both of these contractors have been very helpful during our, and helping us to advertise our home testing services. And then finally, we have a letter of agreement with CalPEP, the California Prostitute Education Project. And about 3 years ago, they started offering rapid HIV testing services in our county. And the wonderful thing about them is they provide services after hours, sort of late night testing, and then on weekends. So it complements our testing services. See next. Next slide. So this is a map of our county, and the way we refer to Contra Costa County, we like to talk about it in 3 regions. So we have the West County region where the anchor cities are Richmond and San Pablo. We have the Central County region where the anchor cities are Concord and Walnut Creek, and then East County where the anchor cities are Pittsburgh and Antioch. And this is a map of sort of the new HIV infections over the time period of 2015 to 2017. And as you can see, we do have definite hotspots in our county where, that we actually, where we focus our community testing services to be able to test folks in those areas. And also in our county, we have about 110 new cases we average a year of HIV, and the African American population in our county is disproportionately affected. They are 9% of the total population, yet they represent close to 30% of new cases. So we really do make an effort to do more and more testing and outreach in the African American community, as well as the Latinx community. We're about 25% of the population, and we also represent 30% of new cases. So our priority populations in our testing program are African Americans, Latinx folks, also men who have sex with men, individuals that identify as transgender, people who inject drugs, and also the sexual partners of people living with HIV. Next slide. So basically, in mid-March, the pandemic hit, so everything was shut down. We were told we could not offer any services, any sort of in-person services to our clients. And also my staff was redirected due to COVID contact tracing for a while. And so basically in the prevention suite, it was myself and Vaya. We were the only 2 here for a while. And we were in side-by-side offices, and we started having a series of conversations, through the wall about, centering on 2 needs, 2 basic needs. One is how can we continue to provide our services to our clients? That's a need that we have. We want to be able to, provide testing services, risk reduction services. And then the other need as a program manager, how can we develop something to keep our employees, working, like to give them work to do, right? Even though some of our interventions, continued through the pandemic, we still wanted to also offer testing. And so we came up with this idea of providing the confidential, free, no contact testing services. We do provide the rapid HIV test. We also provide lab-based gonorrhea chlamydia testing, where we offer 3-site testing. So that's done by rectal, throat, vaginal swabs. And if it's a person with a penis, they give us a urine sample. And basically how it works is we set up a 1-hour appointment with our clients, and we give them very strict instructions that when we show up to the appointment, we tell them, okay, we're going to come to your front door and we're going to put a bag in your front door. The first bag is going to contain the HIV test kit inside and a very simple 1-page handout on how to conduct a gum swab. And so what we do is the test counselor puts on PPE, they call the client, they tell them they're there, they go and they put the first bag in front of the client's door, and they tell the client, okay, wait for me, for me to get back to the van. The client takes the bag inside their home, their private space, and they follow the instructions and they do the gum swab. And then they put the sample back into the bag and they put it back outside. While the client is swabbing for their HIV test, the test counselor puts a second bag in front of the door. The second bag contains the gonorrhea chlamydia swabs and or the urine collection cup, and with instructions for each of those tests. And so when the client comes back outside, they see a second bag and they take that and they leave the first bag and they take the second bag inside their house. The test counselor takes the first bag with the HIV test kit, takes it to the van, and they actually process the HIV rapid test in the van while the client is swabbing for gonorrhea and chlamydia. And then when the client brings back the second bag outside, there's a third bag waiting for them. And the third bag is a small sort of lunch-size bag. And the third bag contains condoms and lube, dental dams. It also contains disposable masks, and it contains our sex and COVID handout that we adopted back in April from the New York City Public Health Department. We got their permission to adapt it to our county, and also there's information on the Leo consent, because we do document everything in Leo, our testing services in Leo, and then information about the OraQuick HIV rapid test that the client just took. And so that third bag is for them to keep. And then so basically the counselor is, once they get back on the phone with the client, and then they do the counseling and session takes place via the phone. And then by that point, the HIV result is ready. And so then they give the result to the client, their HIV result. And then they let the client know that we tell clients within 7 business days that they'll get the results for the gonorrhea and chlamydia testing. But usually we get the results back within about 3 to 4 business days. And then we call the client and give them the results. So how it works is basically, everything's contactless. The counselor still has to put on the PPE, when conducting the services. The samples are self-collected by the clients in the privacy of their own home and private space. And then we also, we say private space because not everyone has like a home. So, for us, that could be a house, an apartment, a motel room, a car, and we've actually tested in all those locations in this program. Let's see, the HIV test is processed immediately, the results given to the client on the phone. The other thing too is when the counselor gets to the client's house, they do offer the client to stay on the phone the entire time. So you could stay on the phone with the client the entire time to support them through the process. But most clients, they once they sort of understand what the instructions are, they say no, so they hang up and they go ahead and do their swabbing. And then we do call them back to sort of continue with the testing process. Let's see, and like I said, any positive results, we link them immediately to treatment. And then for individuals who test preliminary positive with us and do not have insurance, we have our HIV waiver process. So with that, we're able to get a free blood draw for any individual that tests preliminary positive with us at one of our county labs to confirm their HIV status. And once they're confirmed, then we're able to immediately link them to one of our medical case managers, so then they can get an appointment at one of the positive health centers. Next slide. So this is what, so far, our outcomes thus far. So since April 27th was our first client, since then we've tested a total of 50 clients in this program. Of those, the majority, 31, have tested both for HIV and gonorrhea and chlamydia. So we give clients that option. They can just do one or the other, that kind of thing. 9 have tested for HIV only, and 10 have tested for gonorrhea and chlamydia only. And just special note, of the 10 clients that have tested for gonorrhea and chlamydia only, the majority of them are individuals living with HIV that want to test with us for gonorrhea and chlamydia. We've had 0 preliminary positive results, and 7 confirmed gonorrhea chlamydia test results. And all 7 clients, were immediately linked to treatment, whether with their own provider or, at their closest Planned Parenthood or at one of the county clinics. And then also we're offering them testing 3 months after their treatment. And then the demographics of the 50 folks that we've tested, the majority, 70% identifies male, 30% identifies female, including 2 transgender women. Of the male identified individuals, 80% identifies MSM. And of the 50 folks that we've tested, half identifies Latino, 22% is white, 16% is African American, and 12% is Asian Pacific Islander. So for the most part, these demographics do fit the priority populations that we're trying to reach in our testing program, but we can do a better job at reaching and testing more African American folks in our county. And then everything that the services that are offered in this program are offered in Spanish or English depending on the client's preference. So we have test counselors that can offer services in both languages. Everything in writing is in Spanish or English depending on what the client prefers. Same thing with the condom bag. Like if the client is allergic to latex, we just make a bag that's that contains non-latex condoms. And then of the 50 clients that we tested, 10 had been monolingual Spanish-speaking clients. And then the other thing is we also, for folks that did not want to test with us, but wanted the condoms and lube, we also offer condom and lube drop-off services as a standalone service. And so we've provided 34 condom and lube drop-offs to an additional 34 clients, sorry. Okay, next slide. So in order to make this happen, what has to be done? So one is we really, you really do need support from your local public health leadership. So when Maya and I sort of came up with the idea, our director and our program director and also our STD controller were very supportive of it. And then the next person I reached out to was our health officer. And we're lucky in Contra Costa County in that our health officer is an HIV specialist, and he has been a champion for PrEP and HIV testing, for his entire career that he's been with Contra Costa County. So he was also very supportive. But you also have to rethink how you provide services, because in order to make them contactless, and also we wanted to make them paperless as well. You really do need to provide the services over the phone. So we needed the ability to get consent for the services over the phone and to be able to give results over the phone. And up until now, the pandemic, we as public health staff, we were not allowed to give an HIV test result on the phone. So the public health, our health officer had to give us permission to do that, and he did. Let's see. You also have to set up a system with your public health laboratory to process the specimens for the gonorrhea and chlamydia testing and to send the results to us, in a timely fashion. And like I said, last year we did that for 6 months, so we already had that established in our county. And then finally, you really do need a diverse outreach efforts, including social media advertising to get the word out about the services. And so we have it on the county's webpage. We also, like I said before, the prevention contractors are really doing a great job in getting the word out on their social media places and spaces. And one of the first things that we did as far as outreach for this program, so we had 80 folks that we tested for gonorrhea and chlamydia last year at RCC. And so first we actually called those individuals and we said, hey, we have this new idea. We're going to start offering home testing services. Are you interested in, making an appointment with us? And it was interesting because initially, a lot of those individuals were like, oh, they thought it was a really good idea. I thought it was a clever idea. But they said, oh, don't worry. In a month, when all this is over, in about a month and a half, I'll go to the center and get tested. So 9 months later, we're still, we're still in the pandemic. And so so a lot of the 50 folks that we tested have actually come from that group as well. And we continue to call them and offer them services as well. Next. And then our lessons learned. So initially, I would say this is more for when we first started offering the service, that it was really difficult to remain truly contactless. And so even though we would give the instructions to the clients, about wait for us to leave the bag in front of your door. Oh, I forgot to say, the bags that we use are plain grocery bags because we wanted to make it look like a food drop-off, right? So in case anyone's looking, like, why are these, someone leaving a bag there? And that was very common, right, to have that. And so so we would, would give instructions to the client, and so the counselor would be in the van, sort of preparing the first bag, and then suddenly there'd be a knock in the window. So the client was out there knocking, and so it's like, no, go back in the house, and then get back on the phone, and but kind of go through the instructions again. And also too, as test counselors, we're trained to be client-centered, so we're trained to provide services directly to clients, right? To do counseling and education, and to be, in front of them doing this. And so it was hard to do all this on the phone, to sort of translate that work onto the phone. But the more we do it, like I said, the better we get at it. And also too, I'm the person that takes all the intakes when community members call for the service. And they are a number of particularly younger MSMs, like after I explain the process to them, like what we do, then we come to the home, they test in the privacy of their own homes. Have said to me that they cannot, for different reasons, they don't feel safe to test in their own home, right? So this program is not, ideal for some folks in the community. And also too, the reality is you need to have a phone in order to do this, because again, everything is done by phone, right? Let's see. And then we learned a lesson that we need to gather information on how to get to the front door of private space. A lot of our, especially in certain areas of the county, a lot of folks live in very high and sort of impacted, dense neighborhoods, a lot of apartments and that kind of thing. And so we need to know, how is it, how is there a gate to get to your door? Is there, a gate code, or if it's a private home, like is the gate unlocked so we can get to your front door, that kind of thing. So we need information. Is it okay for us to park in front of your house? Like some people don't want a county van parking in front of their house, right? So we need to get that information up front. And then lastly is, if a client does not confirm the day of the appointment, we've learned that we have to reschedule them, because initially we would show up, when they were supposed to be home and they weren't there. So, which is a little interesting since we're a shelter at home, right? But yeah, so we've learned that we have to really, before we actually go out to the client's house. Like I said before, we're a medium-sized county, but we're still 700, square miles big, right? So to drive, 2 hours to someone's house and then they're not there, that's, doesn't work out for any of us. Let's see, I think next, I think that's it. Yes, okay, so I'm ready. That was my presentation. Thank you.
Thank you so much, Obiel. Great presentation. And so now I'm just going to stop sharing those slides, and I'm going to turn it over to our next presenters. So I'm excited to introduce our next speakers joining us from San Ysidro Health, Lucia Franco, who is the Prevention and Testing Manager, and also Jasmine Arias, who's the Outreach and Testing Supervisor. Welcome.
Thank you. Good morning, everyone.
Good morning. Hi.
All right, give us 1 minute to get set up. All right, my name is Lucia Franco, as Elena mentioned, and I oversee prevention, testing, and outreach programs at San Ysidro in the HIV department. And Jasmine is our testing and outreach supervisor, which she oversees the direct day-to-day of those programs. Next slide. So a little bit about our agency. We started in 1969 with a group of women that were located in San Ysidro, and I'll show you a map later, but that is the community right next to the Tijuana border. And they found that it was really difficult to get medical care in their community. So they often would have to travel to central San Diego, which usually took a long trek and a long time. So they started to work with some doctors from UCSD and bringing them over to the community of San Ysidro. And there is where our health center started. And then San Ysidro Health today, so we are an FQHC. We see about 95,000 patients a year. And again, this is a few years ago, so this number has increased. The majority of our patients at the clinic are Latino and are below the poverty level. and about a little over half access Medi-Cal, and we have about 30% that are uninsured. Next slide. And a little bit about our community. As I mentioned, we're the border town right next to Tijuana, which is the busiest border crossing in the world. And so our population consists of a lot of folks that are transborder. So meaning they have, maybe they live across the border and work at San Isidro, or they have family members. And so they travel across the border a lot. Next slide. And we're stationed in the HIV department, which we have about 20 clinics countywide at San Isidro. And at 3 of those locations, we do offer HIV services, which is our main clinic, which is in San Isidro Health, or San Isidro, and King Chavez, which is in Southeast San Diego. And we have a clinic in Chula Vista, which is in between both of those. And at each of our sites, we do have a corresponding drop-in center where we have most of the HIV operations and social services stationed in those locations. Next slide. And a little bit about the services that we offer in the department. We do offer coordinated services, mostly funded by Ryan White programs, which includes case management and access to mental health, food, and transportation. We also offer full medical services, which includes HIV primary care, PrEP services, and all the education that goes along with that. And then for prevention and testing services, we do online outreach. We are also we do condom distribution, home HIV home testing, routine testing, and linkage to PrEP and PrEP navigation. Next slide. And then a little bit of our local EPI. As you can see, that's a map of San Diego County. The dark purple spots indicate a high incidence of HIV, and you can see Central San Diego has high incidence, as well as San Isidro, which is at the very border, southern border of the county. So that means we do see quite a bit of HIV, new HIV cases. Next slide. We have a poll question for you guys. Nationally, and then for your answer, you can just type the letter in the chat, and we'll kind of keep track of it. Nationally, what percentage of people that have HIV are unaware of their status? What do you guys think? A, 2.8%, B, 5%, C, 10%, or D, 14%? And this is a national percentage. So we got a lot of C's and D's. Kind of a good mix of C's and D's. Okay. You guys are on the right track. Next slide, or next. So the answer is 14% nationally. And again, this is a good guesstimate, but those are people that are unaware of their status. Next slide. Oh, and this was from HIV.org. So locally, our number's a little different. We estimate about 10% of folks with HIV don't know their status. So we're kind of closing the gap a little bit on that in San Diego County. Next slide. And I'll hand it over to Jasmine for the rest of the presentation.
Hi, so yeah, when the pandemic hit, we had to comply with the California stay-at-home order, and we limited our one-on-one client interaction, so our in-person rapid HIV testing programs that were in place were suspended. So we started to develop a protocol for HIV home testing. We had several meetings with the OraSure reps, decided that the best way of implementation out of our imagination of how it was going to work out. and then we developed the protocol and finalized it in June, and then started implementation by the end of that same month. We developed within our team this beautiful flyers that we started promoting through social media. And we also developed a HIV home test video. When we received our kit, one of our health educators and myself worked on developing a video where we showed how the test looked, how to take the sample, and narrated how all the instructions for people to get to know how it looked like and start losing the fear of actually doing them themselves. So we had a wait list of people who were interested in HIV testing that we couldn't serve during the time that we couldn't see anyone one-on-one. So when we started implementing this, our health educators started calling them to offer them this option. A few of them accepted and were very interested in it. A few of them said that they were gonna wait because this was supposed to be over kind of soon, and then we're still in it. So how does it work? A client contacts us through either social media or phone. Those are the ones that we've seen that are more common. We also receive a lot of referrals from case managers that some of their clients have a new partner that is HIV negative or of unknown status. So they give us their information and our team contacts them. And then we complete a CAQ, which is a client assessment questionnaire with the client over the phone. And then we agree on a time for drop-off. We actually drive the HIV home tests to their homes or to a confidential space that it's agreed on. Sometimes the client does not want the people who live with them to know that they're going to get an HIV test. So we agree on a drop-off place. It can be Starbucks, it can be a parking lot of Walmart or whatever they want. We, of course, they have to be within the San Diego service area that we work with. And then we agree on a time where they are going to be in a confidential, safe space to take the test. And we have our health educator available to take a phone call with them. And this is part of our lessons learned. Some of them, they do not want to be on the phone when they are taking their HIV home tests. So being flexible has been a huge part of the success that we've had. So some of them just want to text, or they want a few minutes by themselves and they just tell you, I'll call you back. And sometimes they do 1, 2, or 3 days after, but they do follow up. Our health educator, the person that has done the majority of the tests, she is awesome. Our bulk of the tests have been to monolingual Spanish speakers. So she is, she's Latina. She has a lot of empathy for people, so they feel very comfortable, and she is quick to earn their trust. So that has worked wonderfully. And she is flexible and offers a lot of options of how to get back in touch with her. So that has worked really well. So far, we have done 53 home tests. So by the end of June, we had 4, and then it picked up. And by the end of November, we had 53. 7 of those tests have been preliminary positive, and we have confirmed the positive. So our positivity rate is 13.21. So that tells us that even though there's not like a lot of tests that have been done in this period, we are reaching the people who need the test. So yeah, once that they receive the test, we schedule an appointment. But like I said, a key of this has been to be flexible, because we agree on a time for a call, and they don't answer the call, and then when we try to follow up, it turns out that they already took the test. So they send us a part of what the agreement is. they have to text us to one of our secure outreach phones the test results. So they take a picture of the HIV home test kit with the result, and that way we can link them into appropriate care. For people who test negative, we screen them and offer them PrEP, and we link them, if they're interested, to a PrEP navigator. And then if they are preliminary positive, we link them into HIV services. This process is explained before actually performing the test, so that way they are aware that we need to follow up with them regarding this. If we get a preliminary positive, then we link them to a bridge worker. I think I have, next slide talks about that. So we link them into a linkage to care worker, and they will determine the coverage the client has. If they don't have any coverage, they are enrolled into Ryan White with a temporary status, and that covers the HIV confirmatory test. And we schedule a lab appointment for them, and then we schedule a follow-up appointment when they are going to receive their confirmatory result, and they usually get into medical care visit the same day, and often leave with prescription that same day. So this is a test that we're using, is the OraQuick HIV home test kit. So it's an oral swab, results are ready in 20 minutes. And like I mentioned before, preliminary positive results are follow up with that confirmatory lab test with a blood draw. So we explain everything as a regular HIV counseling session, window period, and risk assessment, and link them into the services that they might want or need. And yeah, those are the links for our tutorials. We developed one in English and one in Spanish. And
I included the English link in the chat box. If we can also send those out if you'd like.
And San Isidro actually has 2 HIV home test programs. This is the one for our HIV department, and then we have another one that is in, it's called CHIP, and they target younger population. So they actually do the questionnaire online. They have like different incentives, and they link them into different services that are more interesting. So they are based more like in technology things, but ours, we tend to have like older people in our programs. So yeah, this works. This has been working good. So I haven't looked at the questions, but I think we have time for that later. So thank you. And this is our contact information. Feel free to reach out to us if you have any questions that aren't answered during this webinar. Thanks.
Thank you.
Great. Thank you so much. Thanks for sharing your fantastic program, Lucia and Jasmine. And now I'd like to welcome our third and final speaker for today's session, Jen Hecht, who is the director of the Building Healthy Online Communities Consortium and their Take Me Home program. Good morning, Jen.
Good morning. Sorry, I had to get to the unmute button there for a second.
No,
I apologize.
Okay.
And let me get everything all set up.
No worries. As you get set up, I'll just remind folks to please, feel free to continue sharing and submitting any questions you have using the Q&A function. And also, if you have information or resources you want to share with others in the discussion, feel free to enter those into the chat as well. So welcome, Jen.
Good morning. Thank you so much. And again, apologies for all the technical challenges, but I think we're set up now. So thank you, Elena. Thanks for inviting me to participate. Happy to meet with you all today. And I wanted to just kind of very briefly talk about what I'm going to go over. So just a very quick overview of what is Building Healthy Online Communities, really digging into the Take Me Home project, a little bit about the background and the model, some FAQs that we get about the program, as well as some preliminary data about who's participating and looking at outcomes, and then what's coming next. So just very quickly about building healthy online communities. We're a consortium of public health leaders who are partnering with dating websites and apps and working together to support HIV and STI prevention online. We've worked with a lot of the major apps, including Grindr, Adam for Adam, Growler, as well as Tinder. And we are most focused on making sure that it's easy to find sexual health information and to share sexual health information. So that could mean looking at profile options and making sure that folks have an opportunity to say, I'm negative and I'm on PrEP, or I'm positive and I'm undetectable, as well as making sure those resources are readily available to link out to from the apps. We've done some PSAs in partnership with the apps. We've worked with Grindr's sexual health FAQs, a resource center that they have, as well as developed a website called tellyourpartner.org, which is a partner notification site that launched last year and enables folks who may have been exposed to an STI or who tested positive for an STI to let their partner know that they may have been exposed and they should consider getting tested. And many of the apps are now linking out to that. So this just shows some of our public health partners from around the country and our app partners. But I want to talk about why we're focused on the apps. So we've worked really closely with our partners at Emory. They run an annual study called AMIS, which is a survey of 10,000 MSM. We were able to partner with them to add some questions in. And from that, we could see that 75% of MSM who participated in that study had used a dating app in the past year. So it's definitely a good way to reach MSM. We also know from other research that MSM app users report higher numbers of partners and higher rates of STIs, but they're also more likely to have had a sexual health assessment and to have accessed STI testing. And they're also more likely to report PrEP use. So we see a huge opportunity here to reach MSM through the apps. Again, through the AMIS study, we were able to identify that 22% of MSM on the apps had never tested for HIV. And we saw that that proportion was even higher among MSM who are under age 25, who live in rural areas, and or who live in the South. And this, is much higher than the proportion of MSM, who report having never tested through data sources like NHPS. So in our formative research, we also asked app users which sexual health features they wanted on the apps. And we definitely know there's a very high level of support for home testing. 77% of app users reported that they wanted to be able to order a home test through a dating app. And in fact, that was even higher among folks who'd never had an HIV test. So I'm here today to talk about Take Me Home, which is our platform for home testing, which launched in late March. And this service enables people from around the country to order a home test kit for free. Our goal with this program is to address barriers to testing by making participation as easy as possible for both the participant as well as the health jurisdiction. So this is what our model looks like. We've leveraged our excellent partnership with NASDAD for this project, and they've helped us coordinate with state and local health departments who want to participate. So health departments who are interested can sign up through Building Healthy Online Communities, and then we work with NASDAD to get the payment all set up. And NASDAD also oversees our contracts with our vendors and accepts payments on behalf of those health departments. What's important to know is that health departments do not need to take care of any of the logistics like packing, shipping, ordering kits, or even hiring staff. And because of the deep partnership and relationship we have with these apps, we've been able to include links in the apps to this service, as well as a lot of free ads that promote directly to consumers. So this shows you a little bit of what the site looks like. The experience for participants would be that they would see an ad or a link on a dating app. And it takes them about 1 minute to order a kit and about 2 minutes for the process from beginning to end. There are just a few very simple questions that they need to answer in order to determine their eligibility and then to enter their name and address to order a kit. And we really developed the site keeping in mind how to keep users engaged throughout the process and keep the process as simple as possible. I want to note here that jurisdictions have the option of enabling users to order just one test for themselves or up to 2 tests, which they could then give to a partner or a peer. And we get a very high level of response to additional demographic questions that we ask after the ordering process. So we keep the questions as limited as possible so that we can increase the number of people who actually do order the kit, but then we're still able to get quite a lot of information from those folks after they've ordered the kit. So I'm going to touch on a few common questions that I get in terms of eligibility. So in order to be eligible, a participant must be over age 18, haven't had an HIV test in at least a year, and be in a participating zip code. There's a couple important notes about this. So first of all, we started with a number of health departments around the country, and to keep it simple, we started with over 18 because the laws in different states are different. We're currently using the OraQuick kit as well, and that test is FDA approved for 17 and up. But as we move forward with other services, we will be looking to expand the age eligibility and to tailor it to jurisdictions based on what's legal in their particular jurisdiction. What happens when an individual tests positive? I definitely get this question a lot, and I think it's important to touch on this right away. So the first thing is that alongside the the OraQuick test, OraSure does have a number of resources that come with it. One is a 6-minute video that walks the individual through the whole process from beginning to end. But another important piece is that they have a 24/7 hotline, and that hotline enables someone to call if they have questions about how to take the test, if they're nervous or anxious or worried, or if they have a preliminary positive and they want to get information or referrals or support. And I will say I've tested that hotline out myself, and I found them to be very responsive and very, very very supportive. We also have other sets of resources though. So another set of resources is national level data, access to resources and information. So we make sure that we're sharing STI testing information, condoms, PrEP, and U=U information. We make sure we have a testing locator so someone can put in their zip code and find out about clinics near them. And then we have a local information, and that's actually really important. So we want to make sure that when a user uses this service, they're directed back to our website to get local information. And each health department can gather what information they would want a user to see. So they might want to direct users with a preliminary positive to a specific hotline or a specific website or a specific clinic. They may want to direct folks who test negative to PrEP services. So there's a lot of discretion in that, and we think that's a really important piece of this service. In terms of cost, we really look at this as a service from beginning to end. There's a whole series of different components that are included in it, but we do calculate the cost of the service on a per kit basis. So it's $46 per kit, and that includes the free promotion that we're able to offer, the kit itself, the shipping and handling, access to the ordering platform, as well as monthly data reports, and some promotion assets that health departments are able to use themselves as well. So as I noted, we're using the OraQuick kit as well, which is 3rd generation rapid antibody oral swab. But we're also expanding into HIV dry blood spot testing and laboratory testing that uses a 4th generation technology. If participants or health departments, counties, states are interested in setting this up in their own area, we really, like I said, we try to keep it as simple as possible. It's about identifying what your budget is for a project like this. We get the health department set up with NASDAD to get a contract in place. But I say that cautiously because really NASDAD works very carefully to make sure that it's whatever the health jurisdiction needs. So in some cases we found that's a contract, in other cases that's an MOU, in other cases it's a purchase order, and NASDAD will really work with each jurisdiction based on what their needs are. And then it's about gathering the local resources, because as I said, it's very important for us to make sure that users are directed to the resources that they would want in their own local area. And then for promotion, again, we are going to provide a lot of traffic to the website within each jurisdiction. With our app partners, we're able to direct traffic to the specific eligible or participating health jurisdictions. And we have been able to leverage a lot of traffic through those free ads. But we also encourage health departments, if they're interested, to promote as well. That can be in partnership with CBO partners, or that can be on their own. And we provide digital assets that can be used for additional free or paid promotion. So since we launched the site, we have sent out over 3,500 kits. We started in March with 4 health departments, and we currently have 15 health departments participating and another 7 that are in that contracting process with NASDAQ currently. We also have had over 30,000 visitors to our site, and about 10% of those have ordered a kit. So that compares favorably to online retailers, which might see a conversion rate of about 3%, and even to other health and wellness sites, which might be at a 4.5% for their benchmark of conversion. So we're really happy about that. And we think that's because we've worked very hard to keep it user-friendly and easy to use. So this is a snapshot of our dashboard that's currently under development. I want to point out here we have 15 participating jurisdictions, and 8 of those are California counties. So we're really, really excited about the high uptake in California. And we've been very excited about the participation of those different counties. And in terms of who's participating, I think what we're seeing here is about a third report that they've never had an HIV test before. So we're really pleased with that, because we really set out to reach folks who had not otherwise been getting tested. When we launched, of course, at the end of March, because of COVID, what we saw is that folks maybe who had gotten tested more recently might also find a service like this more relevant. And so we recognize that, and we'll be working with jurisdictions to be able to modify that eligibility criteria. But again, with the focus originally being folks who had never tested or hadn't tested in quite some time, we're really excited about this, this preliminary data here. And then I want to note, in terms of the breakdown of demographics, that our demographic data keeps shifting as new jurisdictions have signed on. So, we started out with Montana, we started out with Oregon, San Francisco, and Tennessee. And as we've had other states and counties sign up that have very different demographic makeups, we're seeing that our demographics of participants keep shifting. So we're going to keep looking at that. But one thing we've noticed is that about pretty consistently, about 50% of the individuals we're reaching are under age 30. I want to get into a little bit about kind of our outcomes around positivity. So this is a little bit complicated. And again, it's a young program, and so we're still learning a lot, and we're certainly learning from our health jurisdictions. But like some programs that we've modeled ourselves on, we worked very closely as we were developing this program with both Virginia and Arizona, who had testing programs and were very supportive and helpful in our development of this program. The way they set this up is that they work to look at to match kind of the data around who they're sending the kits to with their own surveillance data, and look for matches to get a sense of how they're reaching folks. And so we've asked for each of our participating jurisdictions for them to do that as well. And we heard back from 12 out of the 15 participating jurisdictions. However, only 6 were able to complete their matching for any time period. And a lot of that had to do with the fact that there's a lack of capacity at some health departments. And of course, because of COVID, many health departments are seeing activation of their staff. And so that lack of capacity has become even more problematic and challenging. We've also had a couple of health departments say that while we ask for a participant's age, that they need information like date of birth to do that surveillance match. So we are actually in the process as we speak of making that adjustment, so folks will be able to gather that kind of information. So with all of that said, we have had 7 confirmed positives and 5 others suspected. But again, that's only amongst the 6 of the 15. So it's sort of a tip of the iceberg of what we know so far. Amongst those who have been confirmed, we have seen 100% linkage rate. And I'm calling out Oregon here because they were able to complete a match across the entire time, and they started at the very beginning. So they have had a positivity rate of 0.9%. So we might expect to see that across our different jurisdictions, but certainly that's something we'll be looking to as we move forward. A little information in terms of feedback from our participants. I just want to share some of the themes that we've heard back. Why users have participated in home testing. They found it to be easy and convenient. They like testing in the comfort and privacy of their own home. For a lot of users, it's been their first experience testing and it's felt safer to do it in their own home. They appreciate the lack of judgment. And for many, it's been a great way to access testing during the pandemic. So those are some of the key themes that are happening. And we're, again, really focused on trying to reach people who either haven't tested recently or have, experienced stigma or challenges getting into a clinic. So very quickly, I'm just going to talk about a few next steps that we have coming up as we're continuing to expand our service. As I noted, we're continuing to add new states and counties, but we're also rolling out new features. And we're currently beta testing our STI options. So I want to just walk through what that looks like, because unlike the Aura Quick test where that's mailed out and someone collects the specimen at home and they have they get their result at home, STI works as a self-collection. So in this case, a participant would sign in, go through the same experience of ordering a test. They would have to create an account because they're going to have to go back to log back in to get their result. They'll collect their specimen at home, mail it into the lab. The lab will process it. Once that happens, we'll notify them to let them know that it's time for them to log back in to get their result. So another thing that's important to distinguish here is that in this situation, health departments receive real-time positive results, and so they're able to get the results from all of the participating users. And as we move forward, we're working toward being able to, again, tailor that eligibility criteria per jurisdiction. And we are also in the process of translating the entire website into Spanish. So just a few more details. We're going to have 3 main packages in our lab-based testing. That will include an HIV dry blood spot only, a comprehensive STI test that will include 3-site chlamydia and gonorrhea, syphilis, and HIV dry blood spot. So we will have an opt-out if folks if they're HIV positive, they do not need an HIV test. They'll be able to get the STI only. There's optional Hep C, depending on risk eligibility. And then there's a PrEP panel that's focused on PrEP monitoring. For folks who are already on PrEP, they'll be able to get an HIV dry blood spot and creatinine. We're starting with 3 pilot sites, and we expect to expand this to other sites in early 2021, probably late January, early February. And sites who participate in the lab-based portion will be required to have a medical director to oversee that piece of it. So I want to thank you so much for your time and thank you for inviting me. I hope that I already did answer a lot of your questions, but I can certainly stick on for a few more minutes to answer any questions that have come up. Thank you.
Great. Thank you so much, Jen. I know you have to hop off the call in just a few minutes, and thank you again for joining us today. But I wanted to start our Q&A with a few questions for you, and then we'll move into further panel discussion with our other speakers. So just a couple questions that were submitted on behalf of counties that might be interested in participating in the Take Me Home program. So one is, if a county wants to join, do they need to sign for a minimum number of kits, or is it kind of a fee for service setup?
Yeah, thanks for asking that. That's something I should probably include in future presentations. We do have a minimum of about 100 kits, which translates to a little bit under $5,000. And we do that simply because the time and effort it takes to create the, administratively to get it all started. We want to make sure that it's worth everyone's time, but we've tried to keep that as low as possible so we can have as many, counties or health departments participate as possible.
Got it. Thank you. And then just one more here on behalf of counties who might be interested. So if counties wanted to add a palm card or other piece of media, can that be inserted with the kits that are shipped from Take Me Home? And are there other ways that counties can kind of personalize those kits?
Yeah, that's a good question too. We definitely want to offer some level of personalization. What we realize is that as we've learned more, the the sort of fulfillment process for the kits would probably make it cost prohibitive. So it's certainly something we can explore, but I will say that my preliminary look at that is that it does end up costing quite a bit of extra money to do it that way. But we really do encourage folks to do their own personalization from the standpoint of the local resources section, as well as, because we're providing some digital media, the way that they promote the program may be something that they can personalize. And we're really interested and excited about thinking about how we can be creative around that promotion and reaching other populations in creative ways. So we very much encourage health jurisdictions that are participating to reach out and brainstorm with us, and we will work together to come up with ideas for the best ways to promote the program.
Okay, wonderful. Thanks, Jen. And just before you hop off, we just had a question from someone who wanted you to repeat the cost information. So it's 5,000.
Oh, sorry. So the for the OraQuicks for the service is $46 per kit. So to have, if you're starting with 100 kits, it's going to be about $4,600.
God.
As if you're starting with a minimum 100 kits. However, it's slightly more complicated than that because we did negotiate a discount, and so we can throw in some free kits, which changes all of it a little bit, but round numbers, a little bit under $5,000.
Okay, great. Thanks so much, Jen.
Thank you, and again, thanks for inviting me.
Absolutely. And anyone else who has questions for Jen, I'll be sure to send those along to her after the session, and we'll do our best to get responses back to you. So now I'd like to ask our other amazing speakers to turn back on their videos for our panel discussion. Okay, great. So I wanted to start off our panel discussion with really probably the most common question we received during registration, which is how do counseling services and linkage to care efforts really work in the context of at-home HIV testing, both pre and post testing, and also both for those testing positive and those testing negative. So I know, in both presentations, you touched a little bit on this topic, but maybe starting with Lucia and Jasmine, would you like to share a little bit more about kind of the strategies you use to really help ensure clients participating in your program receive the support services and also linkage to care they need?
Sure.
Jasmine, if you want to cover, you can cover the counseling part, and I can cover linkage if you like.
Yeah. So our counseling part, during the initial call, we talk a little bit about demographics and a little bit about risk factors. We do it in a way that is what is driving you to ask for your HIV test today. So that way we start creating a little bit of rapport and trust with the client. And then we do offer different options for them to follow up. Once we agree on a drop-off, they get to meet the health educator in person, although with the mask and all the appropriate care. But I think that also helps to make it a little bit more personal and to have that trust. And then our health educators ask what's the best way to get back in touch with them, either by phone, text. A lot of them choose text. So showing that flexibility has been instrumental to that's what I believe, to the success that we had, because so far we've received all of the results back. So they sent us a picture, and we've had a client that took some weeks to send us to actually take the test and then send us the result. And we had another client that called and mentioned this, okay, I got a preliminary positive, but I need some time to process it. And then just showing that, okay, we're available here, take the time that you need. And if you don't call us back by this time, we are going to follow up with you because we need to get you into care and all of that. And that helped just to meet the client where they are at, and just showing empathy and flexibility, and not try to make this exactly as it would be in the in-person HIV testing, because it's not. We're living through a weird different time. So that has been helpful. And then just mentioning that we do need the results so they can get more resources that can benefit them, and showing them the benefits that they're going to get if they follow up with the results. That has also helped.
And then for our linkage, so if someone does turn up with a preliminary positive, like Jasmine mentioned, we are lucky enough at San Isidro to have a dedicated linkage to care worker at each region. So they will kind of take over and make sure that they have a lab appointment. Right now we have to make appointments for most clinic use visits. So they're also trained testers, so they have that that ability to continue with the counseling and with the patient. And so they kind of make sure that they walk them through each step, which, you know, the lab, and then they on the back end coordinate all of the care that they'll need. So the same day that they get the results, they have to make sure that there's an appointment available with our HIV docs, and there's case management available, there's enrollment available, so that they can have all of the services in one day. And that's what we do with a regular testing. So it was pretty easy to kind of just, you know, do that. A lot of this is done over the phone, of course, like all the coordinating with the patient is done over the phone or through text. But it does help to have that one person that is their sole responsibilities to make sure that the patient follows through with all of our steps and you know, and continues to follow even after the first patient visit.
Thank you so much. Obiel, I wonder if you also kind of want to comment on that piece. I know your model is a little bit different, but have you seen kind of any impacts of the, you know, the lack of face-to-face contact on provision of counseling and linkage to care services? Ben, I think you're still on mute.
I love when that happens. It's so funny. So yeah, I think like I said before, so we do, you know, the counselor is, you know, in constant contact with the, you know, throughout the entire process and in our model with the client. And so the counseling and is, you know, we sort of in that process. But I think one of the things I want to make clear is that when a community member calls, you know, me, because they call my phone or my office, you know, here phone number, asking about testing services. And so what I do is I actually start the counseling and education at that point, because I think folks need to understand, like, you know, that we are using the oral quick antibody test kit and what that means, right? But also importantly, I think they need to understand the importance of 3-site STD testing. You know, the fact that, you know, you really, you know, we do recommend that, you know, you test the body parts that you are using when you're having sex with someone else. And then, you know, and because if you just test one site and you're negative at that site, that doesn't mean that you're negative in the other, you know, you could be positive in another site, right? And so I think, so I start the counseling process there, and then the DITs, the test counselors, continue that when they're actually offering, you know, the on-site services to the client on the phone, whether at their home and, you know, at their private space. But I did say, you know, before, and we had to get used to that, because, you know, like I said, we're trained to do it in person, in front of the person, in front of the client, and we're trained to read body language, right? And it's hard to do that on the phone. Although, you know, we're getting better at it, because when someone hesitates or they, you know, aren't giving you clear answers, you know, we do utilize the same techniques, you know, the open-ended questions. So tell me more about that. What does that mean, you know, to you? Or when you say that, what does that mean, right? So we're able to do, you know, I think we are getting, as a group of test counselors, better and better. You know, we have to adapt to our new reality, right? Which is this, you know, this work in the pandemic. And then as far as our linkage to care, you know, like the two presenters before said, you know, we're using pretty much the exact same process, you know, with the homeless or the SOBIS clients to link them to treatment and care. And, you know, and again, you know, we start with, you know, if they have a medical provider, you know, right, immediately link them that day to their medical provider, but most of them don't. So then we actually link them to the closest Planned Parenthood for their gonorrhea chlamydia treatment, and or to one of our county clinics. And then we have, you know, our system of care is so that we the public health department, we have access to the medical records of patients in the county clinics. So if we're actually testing someone in the community that is already a member of one of our county clinics, we have access to them, so we can make that linkage to treatment more immediate as well, and connect with their providers.
Thanks, Obiel. I wonder, so one question actually that was just recently submitted that I think kind of dovetails from some of what you just spoke about is, do you have a sense of how many of your home testing clients are using the service because of kind of COVID and the current context and current environment that we're all living in, or more because of kind of privacy and confidentiality reasons where, they might actually not seek testing typically in kind of a clinic environment?
Yeah, because I do ask, in the intake, I do ask, what brought them to our services as well. And also how they heard, about our services kind of thing. And I'm seeing pretty much the same thing that we were seeing before in our focused community testing program, where, we have clients that come to us for their sexual health testing because, even though they might have insurance, that they want to keep their physical health separate from their sexual health, right, for different reasons. And so I'm still seeing some of those clients calling in, for the home services. But I think the majority of clients are calling because they have no other option for testing, and that they really like the idea of testing in their own private space. They like the idea of us, again, being very client-centered, like we're taking our services to them, right? And I think they really like that idea, like that someone's going to come, someone's going to sort of be there, with them through the whole process and support them to do this, and then give them the results. And then really, when we give results, like before, we always emphasize, because the majority of results we are giving are negative results. We always emphasize the education piece of that and the counseling to stay negative, to really, around safer sex, around safer sex options, around getting on PrEP. We can do an immediate referral to our PrEP navigation services. And to really, help them, to help them have the best sexual health as they can have, right, for themselves and their partners.
Thank you. Jasmine and Lucia, do you also want to maybe comment on that question? So for those you serve, how much are you seeing folks who kind of seem to be seeking the at-home testing services due to the COVID environment, where they might kind of otherwise access clinic services? Or, is this really expanding the reach of your testing program to folks who otherwise wouldn't access services?
Yeah, we don't keep track of that data. We don't ask it for everyone, but we have received comments. Some of them were just waiting, and some have mentioned that they appreciate having this option, but they do prefer going in person. But there have been a few that have mentioned that they love this option, and this is what they want. So we are definitely considering keeping this option available once we are able to resume our in-person, because we do see the use for this. We had a client that he was very specific with his request. He was only available from 4 to 5 p.m. because that was the time where their partner was not home, and he was not able to go to a clinic or so it was very difficult to accommodate just doing that. And yeah, it was, we see that it was the only way that he was going to test, even having the in-person option. So yeah, it's beneficial.
Thank you. So before we just kind of open it up to open Q&A, I have one more kind of panel discussion question for all of you, which is, we have a lot of folks on the line today who are either just beginning to implement an at-home testing program or might be considering implementing one. And as folks currently implementing programs, what kind of key advice, I know you shared some lessons learned, but if you have, one or two key pieces of advice for folks considering implementing an at-home testing model like yours. So we can maybe start with Obiel.
Well, since ours includes gonorrhea and chlamydia, lab-based testing. So my key advice is to establish a relationship with the public health laboratory in your county and establish a system of how you're going to be able to, utilize their services. I did forget to mention that, even in our county, our public health lab charges our program. So for every body part that they test for gonorrhea and chlamydia, it's $30 a test, right? And so I know that one of the questions you had asked in our email was what kind of funding are you using for the program? And when Baya and I started having those conversations of sort of coming up with this idea, our main point was, how can we use the resources we have now, right, in a different way, in a new way, right, in a pandemic-proof way, right? And so for the most part, what we're doing in our home testing program is utilizing the same resources, right, that we have now, which, we get a lot of those resources we get from the State Office of AIDS, so we are using the test kits we get from them. And I failed to mention earlier, we've gotten a lot of support from them, so thank you, Matt, thank you, Andrew. But also, so utilizing the same resources in a different way, right, a new way. But for the gonorrhea chlamydia testing, we have to pay, we have to pay, right? But luckily, at the same time that we were thinking about the program, our communicable disease program next door, they were able to get a communicable disease infrastructure grant from the state to sort of beef up and build up their local local prevention efforts around infectious diseases. And to sort of better prepare us for a pandemic, right, which we were starting at the time. And so they came to us and said, do you have any ideas or anything that you want to work on during the pandemic, right, that needs funding? And so they were able to fund us for this fiscal year and next fiscal year to be able to pay for the gonorrhea chlamydia testing. So we were able to, have those funds available, which is great. But God, I forgot the question already. See, this is what happens. I tell me stories and I go into my explanations and you seem to me be that, right?
No worries. Great information.
I hope I answered the question.
No, I mean, I think you mostly did. The question was really about kind of key advice you would give.
Oh, sorry. Yes, key advice. Yeah, right.
Implementing.
So establish a relationship with the public health laboratory, and then try to secure, because there are different funding opportunities available for sort of pandemic, to respond, within the pandemic, and try to see if you can use those funds in a way that that will support your program and existing resources.
Great, thank you. And same question to you, Jasmine and Lucia.
I can say I would definitely assess your abilities and your resources according to your area. In San Diego, we have a smaller area that we encompass, so it was easier for us to home deliver our tests. We have specific funding that we had to, request the purchase of our test kits from the state. So kind of assess what your area looks like. If you live in a rural county, it might be more beneficial to maybe use mailing services to mail your test, because driving would probably take too much time. And like OBL said, have a relationship with your county lab department. In San Diego, we stopped sending our labs to the county because of COVID. They were kind of overwhelmed with COVID testing. So then we had to kind of reassess within our own lab system. So kind of, I guess, just assess what you can do and then kind of go from there. Since this is kind of new, there's really no blueprint for doing this, so it's kind of a cool time to kind of be creative with what you have, and also obviously taking into account the population you're serving is really important too. Jasmine, what do you have?
Yeah, back when we were developing the protocol, I also logged into different webinars of other programs that were already implementing this from before COVID. And I think the best advice I heard was make peace with the fact that you're not going to get every result back. So that put my mind at ease. Like, yeah, you're not going to be able to control everything. So far, we've received all of our results back, but I know that that might not always be the case. So that just helped me, because I'm kind of a perfectionist. So that helped me just relax a little bit and just try to anticipate what the needs were going to be, and then just have a mindset that you're going to adapt. Things are going to be different from one day to the other, especially during this COVID time. Things change. One day is stay at home, and the other day is okay, you can go a little bit out, and we're opening a little bit more services, and then never mind, we're back to square one. So it's just quickly adapting to the changes, and yeah, that's it.
Thank you. So now for our last 10 minutes or so, I'm just gonna kind of go through some of the questions that were submitted throughout the session today. And so let's start with a question for you, Obiel. Do you have an appointment schedule for the services? And is there any sort of fee for the clients?
Yeah, so we're able to provide our home as well as swab testing services Monday through Thursday because the public health lab is not open on weekends. And so we're able to provide the gonorrhea, chlamydia at-home testing services. We offer 9 in the morning to 7 p.m., you know, because I can just sort of stagger the staff. And there are absolutely no fees. But you know, when I do that, like when I'm doing the intake and I'm talking to the client, if the client does say that they have their own medical home, right? So my first thing is, well, you know, so I try to support that they go to their own medical home to do, you know, because they can get a blood draw for HIV testing, they can do the gonorrhea, chlamydia testing. But like I said before, there are certain clients that want to keep their sexual health separate from their physical health, right? So I do try to do that kind of counseling, but we don't charge for any of the services. So there are no fees.
Got it, thank you. We got a question for both presentations, really actually a couple of times about promotion of this programming. So Lucia and Jasmine, can you say a little bit more about how you're promoting the at-home testing program?
Yeah, we use more social media, but the main part for us has been word of mouth. So we've had our main health educator that's HIV testing. She's been with us for over 10 years. I want to say like close to 15. So the community already knows her, and a lot of them were just waiting for in person. So she called them and had that option available for them, and then they have referred other people for the program. And then like I mentioned during the presentation, case management, when they have clients that they mentioned they have a new partner, they are quick to offer, oh, we have this HIV home testing option. So we have received a few referrals from that, and then our social media.
Yeah, and we also, as part of some of our prevention and PrEP programs, we have the ability to purchase ads in dating sites like Grindr and Scruff. So we get some referrals from there. And of course, our Facebook and Instagram accounts.
Wonderful, thank you. And how about for you, Obiel?
Yeah, it's the same. You know, we're using the websites and the social media spaces and places, and our prevention contractors, like I mentioned before. Also, we also provide prevention services to our clients living with HIV. So we have a senior health educator that works with them, and in each of those sort of risk reduction counseling sessions, they're done on the phone or on the computer, you know, virtually. She does offer them our home testing services and condom and lube drop-off services. So that's what I was saying before, that a number of the folks that just tested for gonorrhea and chlamydia in our home testing program are people, you know, are some of our clients living with HIV. So we advertise it that way as well. And then we're doing this we got some funding to do a COVID prevention education for some of our clients as well. So we reached out to about 100, I think it's 108 clients in our medical case management system, and she's provided one-on-one COVID prevention education to about, I think we're at 68 clients. And everyone, you know, of those sessions, in that session, you know, she talks about our home testing services. So we advertise that way as well.
Great, thank you so much. One other question we just received is really about kind of follow-up and retention. And so do you all have any sort of incentives as a way to kind of make sure folks follow up with results, and also that you're able to ultimately link them to care? And if so, kind of what does that incentive program look like, and how much do you offer? So we can start with, Lucia and Jasmine. Thank you.
We do not we do not offer incentives for our home testing, but as Jasmine mentioned, our CDC funded program that focuses on youth, they do, and they kind of manage that more virtually, and I think they do e-cards once the person logs in to get a test. So yeah, I mean, no incentives on our end.
Thanks. How about for you, OBL?
Yeah, same here. We don't offer incentives. You know, I guess it's because, you know, the clients that we provide these services to, they for the most part, they call us, you know, to sign up, you know, to inquire about the services. They go through the whole process. So they really are motivated to get their results. And then once, you know, for the 7 positive clients, very motivated to get to treatment, you know, that day or the next day. Interestingly enough, even though when I provide education about gonorrhea and chlamydia, sort of general information, I say, you know, most folks have no symptoms, right? You know, and our 7 were asymptomatic. So that, you know, that goes to prove why it's important for people to test the body parts that they're using for sex, if they haven't tested them in a while. And again, depending on their, you know, the risk behaviors, to test more often, because, you know, you can have no symptoms and yet have, you know, either gonorrhea, chlamydia, or in, you know, some cases both, and need the treatment right away. But yeah, but we don't offer incentives.
Got it. Thank you. So, another question we received, and this might be our last question for today, but again, for all other questions submitted, we'll be sure to follow up after the session. So this question is, do you anticipate continuing this new model once we return to the new normal, so post-COVID life one day? Yeah, so I'd love to start with Lucia and Jasmine, and then we can go to OBL as well.
Yeah, as Jasmine stated, this has been pretty successful for us, and we've found some folks that prefer this to the walk-in testing. So I think this is something that we are planning to keep in addition to our community testing once we can go back to normal.
Great.
Yeah, I would say, yeah, for us as well. Yeah, we plan to continue offering home testing. I mean, for the main reason is that, you know, again, like we said before, clients really like the service a lot. And when you look at our testing results, we are testing the folks who are our priority populations in our program. So we are reaching those folks and testing them. Yes.
Wonderful. Well, we are just about out of time, so I just wanted to take a moment to thank you all again so much for speaking today, sharing your amazing programs. And I also wanted to thank everyone who participated with us in today's session. Really appreciate you taking the time to join us. Oh, and I don't want to also forget our IT support, Nick, who helps make everything run. So thank you to him for supporting the session. Please do look out for an email from me. It should be later today or early tomorrow with links to the session evaluation form. We really want to hear, you know, any and all feedback you have about the session to inform future sessions. And I'll also share links that were shared during today's session from our speakers and other participants in that email. And our next session will be coming up on Tuesday, January 19th from 10 to 11:30 a.m. So please do save the date and look out for more information about that session soon. Thank you again and happy holidays.
Thank you. Happy
Thank
holidays.
you.
Thank you.
Bye-bye.
Thank you. Bye.